Fever greater than or equal to 38.3 degrees Celsius lasting greater than or equal to 3 weeks with no diagnosis after thorough evaluation is called fever of unknown origin. In geographic areas outside of the West, the proportions of cases of fever of unknown origin due to neoplasms and non-infectious inflammatory diseases are similar. Fever of unknown with hypercalcemia plus polyclonal gammopathy, think sarcoidosis. Fever of unknown origin with monoclonal spike, think lymphoma or multiple myeloma. Always confirm before corticosteroid therapy. PET-CT is useful only when basic evaluation is unrevealing and biopsy target unclear. Now another topic is syncope. Neurally mediated syncope is the etiology in the vast majority of cases. Orthostatic syncope in older adults is associated with higher morbidity and mortality, often due to cardiovascular comorbidities. It's very common with a lifetime incidence of around 35 to 40%. It increases with age due to autonomic dysfunction and polypharmacy. In Ramsay-Hunt syndrome, herpes zoster oticus with vestibulocochlear nerve involvement. Appropriate treatments include antivirals, glucocorticoids, vestibular suppressants, and rehabilitation. Unidirectional horizontal nystagmus is most consistent with a peripheral cause of vertigo. Now coming to gentamicin. Gentamicin is the most vestibulotoxic of the aminoglycosides. Streptomycin and tobramycin can also cause vestibular injury, but less commonly. Vestibulodexicity manifests as imbalance and oscillopsia, not vertigo. The head impulse test is the bedside hallmark. Presence of bilateral corrective saccades confirms diagnosis. Hearing is often preserved because the lesion is primarily vestibular. Risk increases with prolonged therapy, renal impairment, and co-administration with loop diuretics. The condition is irreversible, so early recognition and cessation of the drug are critical. Vestibular rehabilitation helps patients adapt via visual and proprioceptive compensation. Always monitor aminoglycoside levels and renal function during long-term therapy. When aminoglycosides are needed, for example, endocarditis, use once-daily dosing to minimize toxicity. Another topic is chronic fatigue syndrome. Always exclude common causes, thyroid disease, anemia, diabetes, depression. Medication effects before diagnosing CFS. Thyroid function testing, TSH plus or minus free T4, is an essential initial screening step. EBV and Lyme testing are not recommended unless there is compelling clinical evidence. CFS is a diagnosis of exclusion. Supportive but not diagnostic lab abnormalities include mild up arrow ESSER or down arrow cortisol. Management focuses on symptom-based therapy, graded activity, sleep hygiene, and psychological support. Exercise intolerance that worsens fatigue, post-exertional malaise, is the hallmark distinguishing feature. Avoid labeling fatigue as CFS prematurely. Many cases have treatable underlying causes. Consider sleep study if symptoms suggest obstructive sleep apnea. Depression screening should be part of routine fatigue workup. Patient reassurance and setting realistic recovery goals are essential for long-term care. Now coming to neuromuscular localization. If proximal weakness is more than distal weakness, think myopathy. If distal is more than proximal weakness plus areflexia plus sensory loss, think neuropathy. Normal sensation and reflexes strongly suggest muscle disease. Babinski sign or spasticity localizes to UMN brain spinal cord, not muscle. Mild atrophy in myopathy is from disuse. Severe atrophy plus fasciculations right arrow LMN disease. Common activities limited in myopathy, climbing stairs, rising from chair, lifting arms overhead. Next step in evaluation, serum CK, EMG, and possibly muscle biopsy for diagnosis. Always review drug history, statins, steroids, alcohol, in proximal myopathy. Reflexes are preserved until very late stages of myopathy. In dermatomyositis, look for heliotrope rash and Gottron papules with similar proximal weakness.